So tonight's topic is real-world evidence for medical cannabis, too strong to ignore. And the context of this, just briefly, if you give me a couple of minutes before I go on to the speakers and a brief introduction to the society, is of course that cannabis is a botanical. But there is a tendency in many senior medical circles, I suppose you could say, and governmental bodies around the world to treat it as if it's a pharmaceutical product. And put it into or compare it to the evidence that you get for pharmaceuticals. In other words, largely the gold standard is double-blind placebo-controlled studies, which of course is the right way to go for a single molecule pharmaceutical product. But cannabis isn't a single molecule pharmaceutical product, as all of you probably will know. It's got I think the number now is 147 cannabinoids, over 100 terpenes, a similar number of flavonoids, all of which have some largely positive medical properties. And so the subtlety of the plant really does not lend itself to a pharmaceutical approach to its assessment of the evidence for its efficacy and side effects. And what I strongly believe we have to do these days is not dismiss the double-blind placebo-controlled studies, of which there are quite a few for cannabis, particularly in the context of pain, a little bit now in the context of epilepsy, historically for spasticity. So there's not no pharmaceutical type placebo controlled double-blind evidence at all, but there is a massive amount of real world evidence, and that's now an accepted term, I think, for a lot of the different ways of looking at evidence, such as observational studies, N of 1 studies, case studies, etc., etc. And if we look at all that weight of real-world evidence, I think nobody would seriously doubt the efficacy and safety of cannabis. Now, I'm not saying at all that we've got enough evidence. We will never have enough evidence, particularly with the huge variety and complexity of the cannabis plant. We'll be researching it for decades to come and unraveling its multitude of properties. But my view is there's a really strong real-world evidence base out there at the moment, which many of the governmental bodies are largely ignoring, particularly, for example, in the UK, looking at the evidence produced by NICE in the UK, which really just looked at that pharmaceutical evidence and said there wasn't enough of it to really warrant prescribing, which I disagree with. So that's about tonight's topic, real-world evidence for medical cannabis, too strong to ignore. What we wanted tonight, we have three speakers, which I'll pass over to in a moment. They're not going to talk in a sort of traditional medical way of talking for half an hour with 10 minutes of questions. We've changed the format here, so the speakers will be talking to us for just 5 or 10 minutes, roughly, just introducing the topic. And probably what we'll do, unless there's burning questions, we'll pass from one speaker to the next and to the next, and say half an hour. And then that gives us a good long time for a forum. We wanted this to be a discussion forum, a virtual round table, and we've got there's about 250 people registered. So we have a lot of people who I'm sure will want to ask a lot of questions. We hope so. And the speakers and me, if need be, will help try and answer these questions. And it's difficult to have a debate in this sort of Zoom format, but we can certainly put your questions on the chat function. And the speakers and I and Kate behind the scenes there will be screening them, and we'll answer them, try and answer them all, unless there's far too many to get through. We have a sort of hard stop at an hour and a half. We don't have to last that length of time, but we have up to about 7:30 if we need it. So we hope we'll have an hour of questions and answers and general toing and froing of debate, starting with half an hour from the speakers. So before I pass to the speakers, that's me. I should have said, I didn't say who I was, did I? The slide says it for me. I'm Mike Barnes, and I'm chair of the Medical Cannabis Clinicians Society. That's the hat I'm wearing tonight. At least I'm a neurologist, an adult neurologist. We have two pediatric neurologists today. So that's me. But just before we start, I've got a slide on this, but I thought I'd put it at the beginning rather than the end in case people start sneaking off at the end and going off for their meals and things. I just wanted to do a minute on a sort of advertising piece of Medical Cannabis Clinicians Society. I'm sure we have about 150 members now, but there's 250 or so meant to be joining us tonight. And I hope that many of those who are not a member will join the society. It's called the UK Medical Cannabis Clinicians Society, but actually it's becoming international. We have members now from, let me think, Ireland, Australia, Uruguay, the States, Canada, I believe, and 1 or 2 other European countries. So what we might do soon is rename it the World Medical Cannabis Clinicians Society, but that's a discussion for another day. But we're very open for members to join us. We'd love more members to join us. And just briefly, what we offer, if you look on the website, I'll give that in a moment, is peer support and for new prescribers. It's really important, I think, not just have the basic knowledge of cannabis, but of course the mentoring and the support, because it's a little bit different prescribing cannabis than it is of a straightforward new pharmaceutical. So we offer that peer support and networking. We have events like this. We have training. We now do a monthly training in collaboration with Drug Science. We produce, I think, some really good, I would say that, wouldn't I? But I think we're really good practical guides, and there's some on the screen there. We have how to begin prescribing medical cannabis. We have frequently asked questions on CBD. We have the guidelines we've produced. A new edition is just coming out on how to prescribe. It's a bit UK orientated, of course. So we have a whole range of practical guides for members. We have information on the licensed products available, again, UK. And we may expand that, and expert prescribing guidelines, which is helpful. We have links, of course, to all the basic clinics, how to get a prescription, how the doctors can help by prescribing medical cannabis, how they go about that. We have support 24/7 through our members' Google group. I'm not going to promise that if you Google me at 3 o'clock in the morning, you'll get an immediate reply. So it's maybe sort of 18/7 is the availability, but we have people do reply very quickly through the members Google group. We have one separately for prescribing clinicians, because prescribing doctors, and another one for all members, because we have it's the Clinicians Society, so many of our members are potentially prescribing doctors or interested medical practitioners, but we also would love and do have members from other clinical backgrounds such as pharmacy, nursing, allied health professions, and a whole range of other clinicians. So we interpret the word clinicians widely, but you do have to have some sort of medical, clinical type background to join the society, hopefully not unreasonably. Soon, the work is done. We're just trying to put it into technical format. We have a searchable evidence hub, so you'll be able to type in, say, Crohn's disease and get the relevant literature if that's needed. Sometimes you need that to back up your prescribing, and that will come probably within the next month to 6 weeks. That'll be online. And then have a look at that website and join us if you can. And it's very reasonable price. I think it's £90 for Hannah can nod at me. It's £90 for a full clinician, as it were, and how about half that price for students, medical students or other students. So that's my sales pitch, which I thought I'd get in first. You have to put it, if you stay to the end, you're going to get. That's a brief introduction to the evening. And first thing I'm going to do now is introduce Richard Huntsman. So we have 3 speakers. I'll introduce the other 2 perhaps as we go along, if that's all right with everybody. Richard, as it says on the screen there, is an Associate Professor of Pediatric Neurology at the University of Saskatchewan in the middle of Canada. Who has a lot of experience, not just in pediatric neurology, but also in cannabis. And he was an investigator on one of the various CBD trials, a founder, member of the Cannabinoid Institute of Saskatchewan. So, because Canada is way ahead in medical terms of most of the rest of the world, the only exception really being some of the American states. Canada has sort of led the way in medical cannabis prescribing, and Richard is one of those key prescribers. So, and he's going to talk to us. I'm going to stop sharing this screen at the moment and pass to Richard. Basically, he's going to talk to us about real-world evidence versus randomized control trials and all the associated issues and problems. So, Richard, thank you very much for joining us from Canada. And I will now stop sharing this screen and pass over to you to share yours and talk to us for 10 minutes or so.
Excellent.
Thank you very much for coming.
Thank you very much, Mike. So my name is Richard Huntsman. I'm a pediatric neurologist at the University of Saskatchewan. So I'm just going to set up my screen share right now and start my talk. So hopefully everybody can see my presentation right now. So my presentation is going to be about is really a sort of segue into the discussion that we're hoping to have today regarding the the role of real world evidence in assessing the efficacy and safety of medical cannabis. And in order to do that, I think it's a good idea to have a bit of an understanding of some of the challenges that we've faced doing medical cannabis research, particularly in children here in Canada, and some of the ways that we've tried to move forward to get around that and hopefully incorporate the real world evidence and hope. So this is kind of like a leap into that discussion. So I do have some disclosures I do need to make. I think the main one is that I have been asked by Health Canada to act as a co-chair on one of their scientific advisory committees, looking at how do we regulate health products that contain cannabis for patients in a non-authorized or non-prescription setting. So that could be seen as a bit of a conflict of interest, although it also does give a perspective on some of the discussions which have been had, even here in Canada, about what type of evidence is required to make these decisions. So just a little bit of a background. So there are some differences between Canada and the UK with regards to regulations. And really, the Canadian experience has been evolving over the last 20 years with a huge shift in 2018 with the Cannabis Act, which legalized recreational cannabis on top of the medical cannabis. There are some advantages in Canada that we have over other jurisdictions. So when I talk to my colleagues in the US, they're quite jealous of what we have. The main advantages being in Canada, all cannabis products, including recreational products, are regulated by Health Canada. So there's a federal regulatory framework with regards to quality control and labeling, which really does help with when we're authorizing products for patients, say, who, if I'm authorizing a product that's produced in Nova Scotia or New Brunswick for one of my patients. For patients, especially children, who do require a medical authorization to access cannabis, the regulations encourage a discussion between the parents and the physician so that we can talk to the parents about what are the pros and cons of medical cannabis, and also what do we look at? What do we need to look out for with regards to potential side effects? And also, we now have access to products which can be used by children, and the federal regulatory framework allows us to do multi-center studies in Canada, which really, given our demographics, is a necessity. There have been, as I mentioned, it's been evolved over the last 20 years, but I think the main events with regards to medical cannabis regulation in Canada were when medical cannabis was officially legalized in 2001. The regulations went through several changes, but for pediatrics, it was with the access to cannabis for medical purposes regulations, which were finalized in 2016, which really allowed patients to access cannabis products besides dried leaf. So it really opened things up for pediatrics, because we would not authorize them to smoke cannabis for our pediatric patients. So it allows them to access oils, extracts, edibles, products. So it opened this up for them. The other big shift was in 2018 when recreational cannabis became legalized, which for the most part has helped our research environment, but also it's kind of caused some unexpected challenges as well, which I'll get into in a little bit more detail. So when I first started out the cannabis research that I was doing, this was 5 years ago, the main challenges I faced as a cannabis researcher, we were just opening up the field here in Canada. So really the challenges we had were getting institutional approval at each site. So at my hospital, at the other hospitals where we were doing our study, to get them to actually agree to handle and dispense cannabis products, to allow our patients to be authorized from. Getting ethics approval from each academic center was also very challenging. It took over a year of back and forth with one of the center's ethics boards to get them to approve our study in children with refractory epilepsy because there was concern about the small amount of THC in our study product. And also overcoming the stigma of studying medical cannabis, and it's real, it was there. The vice president academic of another research center in another province wrote to the president of a VP research of my university, basically saying you should not be allowing this research to go ahead. It's not, we shouldn't be doing this type of research in children. So there was still this stigma there. Now, over time, those challenges have changed. And really, almost in a way, it's a side effect of some of the success we've had here in Canada. The main challenges that we faced here in Canada doing cannabis research is access to product, which is Health Canada approved. We've had some challenges with our industry partnerships as well. Some funding is always an issue no matter where you are. There's still some regulatory and administrative barriers we need to face. And given the demographics here in Canada, the relative rarity of some of the conditions we're studying. So access to product. As one of the unintended effects of legalization of recreational cannabis is that some of the licensed producers are now, they're actually facing major economic challenges. They've been hit quite hard economically. And so there's very few producers who are willing to supply products for research purposes, either at cost or for free. And so we have to then pay for it ourselves. A lot of the licensed producers are also very interested in supporting research within a very narrow framework. So trying to convince them to do research in rare epilepsy conditions in children or to provide product, if that can be challenging as well too. And also here in Canada, we don't really deal much in isolates. We deal mostly in extracts, whole plant extracts. So if you want to study isolates for basic science research, etc., it does become that also produces challenges. The actual relationship between research and industry with the licensed producers as well produces its own challenges. So one of the problems we faced is that when we're dealing with our national research funding boards, because a lot of the licensed producers have now gone into the recreational market, the federal boards such as CIHR, these federal funding bodies, now view the licensed producers in the same light as, say, the tobacco and alcohol companies. And so a lot of them are saying, well, if you have partnerships with them, we can't fund you, or we can't fund your research. And so we're really looking for clarity on that with the medical products. Some research groups as well that I'm aware of, they get partway through their study, and all of a sudden, because of the economic challenges these producers are facing, they've had their support withdrawn. And so they've had to stop the studies partway. And we've also faced circumstances where if we've tried to have a partnership, where the industry partners have requested the right to ownership of the data and the right to veto publication of research, which really for us in our research group, we've kind of have felt was not acceptable. Funding, wherever you are, funding is an issue. And, as I said, a lot of the funding agencies have kind of put a barrier up because they view the cannabis industry now in the same light as the alcohol and tobacco industry, and we're looking for clarification. But also within CIHR, when they do funding calls for cannabis research, it's often in a very, very limited research scope, and not very relevant to the pediatric population. So it can be a challenge getting research funding. So we often have to look, say, to our Children's Hospital Foundation for funding for research. And keep in mind too that these studies are very expensive. Our CARE study, where we did an open label study of 20 children with drug-resistant epilepsy, we bought the medical cannabis at cost, and that cost approximately, we had to pay £250,000 to do the study, which we were able to get through our hospital foundation. Once again, there do remain these administrative and regulatory barriers. And the main thing which has happened here in Canada recently is previously, if I wanted to do a study one on medical cannabis and another study on medical cannabis, I would have to get a Health Canada research license for each study. And it's very time consuming. The cogs of bureaucracy move very slowly. Now, what Health Canada did to try and counter that, or to try to move things along, is they've now started up this an institutional research license. So say, for instance, at University of Saskatchewan, once we got that license, every single researcher at the University of Saskatchewan who wants to do cannabis research would be covered under that research license. So we wouldn't need to apply. So in theory, it's great, it makes things very effective, but unfortunately, there's been a huge delay in getting these institutional research licenses approved. And we put our application in November 2019. We just got it approved. And one of my colleagues who had a funded study had to abandon the study because the funding period ran out while we were waiting for that research license. The other thing too is, in my field and in Evan's field, there is a relative rarity of the conditions that we're studying with these drug-resistant epilepsies, such as Dravet syndrome, etc. Canada, we have a very small half the population of the UK, spread out over a vast distance. So if people want to know where Saskatchewan is, it's right bang in the middle of that map there. So if I want to drive down to Toronto to visit Evan and discuss a research study, it would probably take 25 hours of driving straight to get there. So, the distance is a barrier. Most academic centers, such as University of Saskatchewan, we cover a huge area with small population. So, in Saskatchewan, we only have over 1 million people in our area. So it's very difficult to do a single center study. We need to do multi-center studies spread out over these big areas. We've been a victim, in a way, of our own medical cannabis regulation success. So patients here in Canada have quite good access to medical cannabis. There's still challenges accessing it, cost, etc. But it's becoming more and more difficult to find patients who are cannabis naive, especially in our epilepsy population, pediatric epilepsy populations. But then that makes a great argument for using real-world evidence instead of the randomized clinical trials. Now, despite all of this, Canada has some definite advantages. Once again, our federal network. So if I want to do a research study that is based in several centers across Canada, I don't need to get regulatory approval in each province. I get it through Health Canada. And I find Health Canada has been, they've been actually very helpful in getting studies approved. When I put my application in for the PRE study, the feedback I got was all very positive feedback, really aimed at just ensuring patient safety. Can you look at this to, can you add this blood work to make sure that we're not seeing this potential side effect, etc. So it was very constructive feedback. And Health Canada and CIHR are sensitive to the need for more pediatric specific medical cannabis research. We're really coming around to that. One of the things which we've done in Canada is we do have these pediatric research networks across Canada. So the Maternal Infant Child Youth Research Network, which is funded by the federal government, funded by Health Canada and CIHR, they brought together a group of Canadian pediatric cannabis researchers called the Canadian Childhood Cannabinoid Clinical Trial Network, or C4T. So we have a group of researchers all across Canada with a common goal and supporting each other in our research studies. And it was actually through C4T that I first met Evan at a meeting. And, we sat down, we discussed things, and we just clicked. And, and we found we had, really similar research interests. The other thing too is that, to help fund our research studies, we've set up partnerships now, or trying to set up partnerships with the licensed producers here in Canada to have for them to be able to donate money or fund research projects, but at an arm's length, so that the licensed producers aren't dictating the research. They fund the researchers, and the researchers then decide how the funds are spent, what kind of studies we do, and with a peer review process built into it. So say, for instance, with the Saskatchewan Health Research Foundation, they have said they would provide this peer review process for applications that go in. So we're trying to set that up right now. So I think I got 1 minute left, Mike, I think. So, okay. So I thought, this would be a great segue to introduce the questions about where does real world research, where can this be the most helpful? And I thought of a couple of circumstances which I think would be really relevant to our colleagues in the UK. So the areas where I thought where research would come in would be, say, for instance, long-term safety data for, say, cannabis extracts in children, which really isn't amenable to a clinical trial, but much more amenable to real-world evidence. And things like efficacy studies for non-life-threatening medical conditions, and also comparative studies comparing different types of extracts as well too. So not just a 120 or 110, but even the different 120 extracts that all have different concentrations of varying cannabinoids and terpenoids as well too. So maybe using the RCTs as the framework or the foundation, and then real world evidence to expand on that. But I thought I'll just say that to kind of get the conversation going, and I'll stop sharing right now.
Lovely, Richard. Thank you very much for that. That's a really interesting experience from Canada. As you say, you're a long way ahead of us. We've got a long way to catch up. So thank you for telling us how it's going there. That's good. And thank you for your time. I'm going to move on. There's a couple of questions come in, but I think they're more generic questions. So I think what we'll do is just carry on with Evan and then Becca, and then we'll take the questions at the end. So can I move on then to two things, to introduce Evan. First of all, I do have one apology to make, because this was a dreadful error. I apologize to Matt Hughes if he's here. This is a three-way organization: the Medical Cannabis Clinicians Society, one; the Jamaican Medical Cannabis Corporation, which I've already thanked, and many thanks again to Evan for facilitating that link with them and for helping to get sponsorship from them, but also with MedCann Support, which is an excellent support organization for families and people with medical cannabis, particularly, of course, children with epilepsy. And Matt Hughes started that, who is somewhere in the ether. I can't see his face, but he's out there somewhere. And Hannah's on that board, and others attending, no doubt, are on that board as well. So I admit it, I do apologize to say thank you also for MedCann Support for your help and support in organizing this event. And of course, as I said, to Evan for help with his organizing his Canadian and the Jamaican corporation, and for putting us in touch with Richard and others for the other seminars. So Evan, thank you. So I'm going to move on to your talk after that. And Evan Lewis is also a pediatric neurologist, also working in Canada at the Neurology Centre for Toronto. I had a lot of practice to get Toronto pronounced in the proper Canadian way rather than Toronto in a British way. So I probably got it completely wrong anyway, Evan, but that's where you are, Toronto. And you've obviously been involved with not just pediatric neurology in general, but with pediatric epilepsy, refractory epilepsy in particular, for many years, and consequently in the last years also with very extensive experience of prescribing of medical cannabis particularly for children with refractory epilepsy, and probably some other conditions as well. So Evan, I'll pass over to you. Many thanks again. And if you want to share your screen, I'll let you say your piece. Thank you.
Great. Thanks, Mike. I appreciate it. And welcome, everybody. It's a pleasure to be here to share this with you. And, for a little bit of a background, it was a great synergy for all of us to come together, including Matt's group, the MCCS, Neurology Centre Toronto, and then JMCC support. So this is shaping up to be quite a great audience. We've got big numbers here tonight, and hopefully as we get through this and myself and Dr. Moore's chat, we can have a good conversation following this. So I think Richard has set the stage quite well in terms of experience with regulations and regulatory bodies within a country that has provided medical cannabis therapies for a bit of time. So my piece here is going to be more looking at some of the evidence that's established predominantly in epilepsy. I'm an epilepsy specialist. I also deal with many other neurological conditions with medical cannabis. Epilepsy, though, has quite a strong body of evidence. So quickly going to go through that and then kind of talk about some real world evidence with my own experience and share a case with everybody here tonight. And that will hopefully kickstart the conversation from an evidence-based point of view and some of the other observations that we make in the real world. So what's I think really important is when you dive into the evidence for medical cannabis, you have to have a bit of understanding about what we're talking about. And I think Richard's alluded to some of these things like his isolates and extracts. So I always find when I give talks on cannabis, the audience is quite varied. There are people who are quite knowledgeable and people who are just starting their journey in understanding medical cannabis. So this is a very quick introduction. It's a big table here, but should provide a very solid outline so you have an understanding of what you're seeing when you're diving into the research, whether it be in epilepsy or other areas of medical cannabis. So the first, I'll direct everybody to the last column first here. These are the synthetic products. So what's a synthetic product? That's a molecule that's produced in a laboratory, and it typically is produced regarding one cannabinoid. So an example would be a medication like Nabilone. That's been legal in Canada for quite some time. Nabilone is a synthetic THC molecule that's used in the treatment of nausea and also the treatment of appetite in order to encourage appetite in people who, typically in people potentially who have undergone chemotherapy. It was also used traditionally in pain as well and might still to some degree. The problem with the synthetic medications when it comes to synthetic cannabinoids is they have a very small therapeutic window. So you get side effects really easily. Now, if we compare that to what a purified CBD product is, or CBD-rich extract, what is the difference between these two? Okay, so synthetic is developed in a laboratory, does not come from a plant. Purified CBD products and CBD-rich extracts, they come from plants. So typically cultivators will grow plants that have a high amount of CBD, if you're looking for a CBD type product, and then they'll take them into a laboratory and under their particular extraction techniques, do one or the other. If it's a purified CBD formulation, then what they're doing is they're going to break that down and they're going to try to isolate as much CBD as possible. But like any kind of chemical or chemistry experiment, it's not easy to get something 100% pure. It's actually almost impossible. So what you're left with is a remaining 1% of the other cannabinoids, THC and other various cannabinoids. But predominantly you're talking about 99% pure CBD coming from a plant. You hear this in the literature, you hear it in colloquially as whole plant or pharmaceutical grade. Isolate is often used, but purified CBD is one direct term you can use. Epidiolex is an example of that. It's a purified CBD formulation. Okay, then what's the difference? What's a CBD-rich extract? So a CBD-rich extract is a product that, again, grown from a plant, high CBD. You go into a laboratory and you parse out the CBD amount that one is looking for. So an example might be, and Richard alluded to this, a 1 to 20 oil. By convention, the first is a THC and the second is CBD. When you hear that 1 to 20, that means 1 parts THC to 20 parts CBD. So that might be something like 1 milligram of THC per milliliter to 20 milligrams of CBD per milliliter. And you can design these. So you can have a 2 to 50 or a 2 to 100 you might see. So you might see various different formulations. The idea there is these are predominantly CBD, but do have a significant amount of THC and the other cannabinoids. In the literature, you see them referred to these terms here. So really important to understand that when you dive into the literature to really get a sense of what's going on. And the last thing I'll say here is hemp. What is hemp? Hemp is a variety of the cannabis plant that has less than 0.3% THC. So if you want to extract CBD from a plant like that, then you're predominantly working with CBD. So it might be an easier way to do it, and you potentially can have a different product formed after that. But typically, these are the purified CBD type isolates that come from hemp. Charlotte's Web is from the States is an example of a purified CBD that comes from hemp. Okay, so that sets the stage a little bit. Now we can dive into the evidence and then see how these two different formulations have been studied and which one has more evidence, and maybe have an understanding of why some products like Epidiolex have become approved in certain places like Europe and America. So if you're looking by type of cannabis, so here we go. If you look at the CBD Purified or the Purified CBD formulations, there are 4 open labels and 5 randomized control trials. It's quite a lot of randomized control trials for a medical cannabis product, because often people who are unaware of this, the evidence in medical cannabis, think that there are no RCTs. And Mike mentioned this right at the beginning, that we have quite a few. CBD-rich extracts, there aren't that many RCTs. There aren't that many high-level evidence studies done, and we have no RCTs for the CBD-rich extracts. Here is just a breakdown of the different RCTs, and you can see that Orrin Devinsky and Teal, these are the 2 individuals who were responsible, really the main individuals responsible for the Epidiolex trials in the US. And so most of the RCTs come from those Epidiolex trials. Over on the open label side of the CBD-rich extract, we've got some Israeli representation and Canadian representation. So Dr. Huntsman, who's on the panel tonight, he has done a study in this. With the analysis is still in progress, but Dr. McCoy is another physician who used to work at Sick Kids in Toronto. And so some 2 good studies here, but again, open label studies, not randomized control trials. Now the question is, what can we glean from that, and how can we utilize that evidence? This again is a very busy table, but really important for everybody to see. What I'm trying to emphasize here is the number of people who have gone through the randomized control trials. So these are the 5 randomized control trials in Purified CBD, and that is quite a number of patients. And often this is alluded to as being pediatric trials, but look at the number of adults that have gone through these trials. 125 of the 774, I think that's about 16%. And we don't have the adult numbers available from this trial. So certainly that number is a little bit up, because there were some adults in this 2020 trial, which was in tuberous sclerosis complex. So that's one big number to emphasize. The other is over here. So these are the CBD doses that were used in milligrams per kilogram per day. So if we zero in on the 10 and 20 and come across the column here, you can see that most patients were treated in a range of 10 to 20 milligrams per kilogram per day. Okay, I'm going to hold that thought for one moment, and let's just look at the outcomes here. In each and every one of these trials, randomized control trials with significant number of placebo groups, you have significant reductions in seizures in very complicated epilepsy. We're talking about Dravet syndrome. We're talking about Lennox-Gastaut syndrome, tuberous sclerosis syndrome. For those out there that have experience or understand what these conditions are, you know the difficulty we face with these patients in terms of treating their seizures. For those who don't, you're talking numerous seizures per month, sometimes numerous seizures per day in these children. And you have, compared to no treatment, these children are getting, these children and adults are having significant reductions in their seizures. Not to mention, pretty much every single one of these patients is already on a significant number of anti-epileptic drugs that are not working. And one number that always stands out across these trials for me, we're going to see it when I present quickly Dr. Huntsman's analysis, is the seizure freedom rate. It tends to be somewhere around 6 to 8%, more or less, in these trials. So these, again, are children who have significant number of seizures, and they're able to reduce those seizures significantly. And in about roughly 6 to 8%, they are seizure-free, where they previously were never seizure-free on any of the traditional anti-epileptic drugs. So certainly very strong evidence to support a medication that works in complicated epilepsy. And then coming back here again, why are these numbers important? Well, again, this is the 10 to 20 milligrams per kilogram per day of a purified CBD solution. So when people, say, well, that's great, we might have this data, but what do we dose our patients on? This is a great guide right there for a rough idea about how much these patients might need. So this is pretty strong evidence as an epilepsy specialist when I look at this pool together and look at the action of CBD. Here's just a summary overall when we compare children and adults. As mentioned, there were adults in all those randomized control trials, but really the data on adults is quite old. The real data, the focused data on adults is quite old. But the focused data on kids is new, it's up to date, and here are the main findings here, showing decrease in seizures and that it's safe and tolerable. That's the other point that doesn't come across in that last table, but compared to placebo, there were a limited number of side effects compared to placebo. Okay, so what about the CBD-rich extract? So again, there's been a few studies, 4 of them open label, none RCTs. This is Dr. Huntsman's study. This is really what to focus on here. What are we seeing? We're seeing a % reduction in seizures over a certain time period. When you get to about the 4 to 5 time period, these are each month. So once you get to about 4 or 5 months and we get up to a dose of around 10 to 12 milligrams per kilogram per day, this is what Dr. Huntsman found, an average seizure reduction of 71%. Right? So I'm just trying to highlight that, and these are all showing as patients moved in time, there seems to be a tendency towards a % reduction above 0, which is great in an epilepsy trial. Another thing that's very interesting to point out here is after weaning off this medication in the trial, there seemed to be a persistent decrease in seizures. And the last one is 5 participants here seizure free, again, kind of hitting that number with really complicated epilepsy. And from a quality of life standpoint, you know, all patients here had an improved quality of life, and that probably correlates well with the reduction in seizures. But in my experience, I'm also seeing even patients who don't have a reduction in seizures, they still tend to have an improvement in their quality of life, whether that be more awareness, more interest in the outside world, or just kind of feeling better in a whole sort of different ways. And here, Dr. Huntsman has shown that clearly that we get general improvements, mainly in cognitive, social, and emotional function. Very quickly into the real world evidence. This is from my center here, where I'm the director of. We have a large contingent of medical cannabis patients. At this point now, we're going back into our data and looking. It's over 300. I think I've lost count. It might be upwards about 400 or more at this point. A mixture of adults and children with various different conditions treated in neurology, which are all listed there. Again, primarily epilepsy, but a lot of work in concussion, a lot of work in headache and migraine, autism, etc. So when I first explored this, this was my last trip I think I made before COVID. This was in 2019 when I came to London actually and presented this there to the group. We had at that point really analyzed about 30 of our patients. So what I'm showing here is these are our 30 of our epilepsy patients, and here were the reasons for their epilepsy and the age as well. This was mainly children, maybe a couple adults in there, but in general showing, you know, outcomes in seizures, you know, improved seizure outcomes in 62% and improved quality of life outcomes in 71%. So this is from my clinic here, my patients here, so some real world evidence to back that up. And I want to take this time to show one particular case here. This is a case of Quinn. Quinn was one of my very, very, very early patients that I met. She was a 2-year-old when she had an onset of explosive seizures that were drug resistant. We tried on valproic acid initially and some other anti-epileptic medications. We were able to control the daytime seizures, but she had a frequent high number of nighttime seizures. This was a child who prior to the onset of her seizures was developmentally normal, healthy, no concerns, no neurological concerns, meeting all of her milestones. Unfortunately, what happens in epilepsy when you have frequent ongoing seizures, in time what develops are neurological deficits. So you can just imagine a brain that is constantly not producing normal electrical activity. So all of the functions that the brain provides are unable to coordinate themselves properly, and children start to regress. And this is what we saw in Quinn here. Again, remember, this is a totally normal developmentally normal child who now she had even trouble just standing still. That's what her EEG looked like. If anybody has if you have no experience in EEG, really big squiggly lines that are all bunched together, that's not good, okay? It should be calm and nice with smooth lines, right? That's Quinn's mom, Carrie. She was very brave and kind of going forward with medical cannabis and quite a strong advocate for Quinn, and Carrie and I worked together in helping Quinn going forward. So there's her EEG. Again, pre-cannabis, we started cannabis. Within 2 to 3 weeks, her EEG turned into that. So you can see the difference there. That's what I was trying to say, that very calm, and the waves look nice and appropriate. That is a normalization of an EEG after introducing cannabis. This is not a common thing that happens in cannabis, in epilepsy treatment. It's often quite difficult to normalize an EEG, especially in a situation like Quinn's. And from a neurological point of view, this was about 2 months afterwards, and there she is going from what you see on the left to what you see on the right after cannabis, walking well and climbing cargo nets and being a typical 3-year-old at that time. So this was great. At about 8 milligrams per kilogram per day for 12 months, she enjoyed seizure freedom, everything normalized. Unfortunately, at 12 months, she started to have seizures again. So they broke through. Again, that same similar explosive onset. She had all the neurological deficits came back and the EEG was abnormal again. We tried a few things. I increased the CBD to 20 milligrams per kilogram per day. We tried this cannabis receptor reboot, which is you take off the CBD and you put it back on slowly, and hopefully the receptors restore themselves. Nothing really worked. And there's her EEG there. Again, kind of her EEG gets abnormal and she starts to have, these are seizures right here, starts to have big seizures. Okay, so my understanding of the cannabinoid system, I thought, well, it's a balance. It's a balance of inputs, and CBD and THC work opposite to each other when you start to learn about this. So what my thinking was, okay, well, maybe I've tipped the scale too far in the wrong direction and we've overloaded her with CBD. And here it's really important to understand that there are other cannabinoids also play a role. So I thought, well, let's just add THC. And maybe we can restore that balance we previously had when she was exposed to mainly CBD, but some THC. So we added 0.1 milligrams per kilogram per day of THC at night. Immediately she resolved. Everything resolved within 2 weeks, restored her neurologic function. That was 13 months, almost to the day. She remained seizure-free, and Mom says she's the best she's ever seen. And there it is again, her EEG that became abnormal. We add the THC and her EEG normalizes. So quite an amazing case. Again, one case doesn't, explain or doesn't provide evidence for everybody, but it's a very important signal, especially in epilepsy, right? Epilepsy is very different from pain. It's very different from anxiety, right? There is little to no subjectivity if one is having a seizure. You either are or you aren't, and you can't fake or you can't make your EEG normal by thinking about it, for instance, or perceiving it. So really great real world evidence, and I'm thankful that I was able to share Quinn's case today, as I know her mom would be appreciative of me sharing that with everybody here today. So hopefully this can segue into some more conversation about real world evidence and its importance, and compared to the evidence that's been established.
Great. Evan, thank you very much. That's really, really good talk. It's so exciting, really, to see something like this that works so well, isn't it? And what slightly puzzles me about the pharmaceutical approach is people aren't excited by it. They think, it's such an extraordinary medicine. It's not a cure-all for everything, of course it's not, but it's, it does have remarkable effects in many people. And, I think the medical profession is very slow to embrace something. It's really quite an exciting way to change how we look at our body system, the endocannabinoid system and such like. So thank you very much for that. And thank you for your pioneering work in Canada, to both you and to Richard. And thank you for sharing it tonight.
I have a question for Evan.
Yeah.
So, we've talked about, Evan, you and I, we've talked about THC a lot, and adding THC to our patients with epilepsy that haven't responded as well to CBD as we would like. And, one of the other things we talked about, just to kind of show the complexity of this topic, is THCA. And, one of my Dravet patients with severe epilepsy maxed out on CBD, and I added a small amount of THCA, and Mum reports that the last time I spoke to Mum was that, seizures are better, cognitively is better, with the THCA as well too. So it's a very complex topic.
Certainly.
Yeah, we've tried THCA as well, and I think there are some children who don't get high at all, but they get increased behavioral disturbance on THC. And then obviously using THCA, for those who don't know, THCA is the acid precursor, which is non non-high, non-intoxicating, non-psychoactive. And so it does seem to have a very useful effect in some children. A little bit difficult, not easy to get, not easy to make, but it is available. And there's a couple of larger cannabis producers that do have THCA now, don't they? Probably more than we've got in this country, in Canada, I'd imagine. And maybe afterwards, there's also other things that people are beginning to try, like CBG for its anti-inflammatory effect in inflammatory type epilepsies. So there's I think, as I think Evan has emphasized, and you've emphasized, Richard, it's not just the headline CBD or the headline CBD THC, it's all the other minor cannabinoids and terpenes that clearly have a role to play. Exactly what that role is in every type of epilepsy is still to be teased out, but they certainly have a role. So, thank you. Some people are raising their hand in this Zoom thing, but if you could type a question in on the Q&A, then we'll answer it. I think what would be sensible to do is to pass over to Becca, and then for 5 or 10 minutes, and then we'll go through the questions one by one, if that's all right. So can I introduce Dr. Rebecca Moore? Rebecca is a psychiatrist, was one of the very early cannabis prescribers in the UK, one of the elite team of about 4 or 5 of us who started things off. If I can call you an elite team now, you're an old hand at it, Rebecca. Rebecca, of course, is not a pediatric neurologist, a different perspective, a psychiatrist, particularly experienced, and her practice is largely in the PTSD following birth trauma. Is that fair? And anxiety and mood disorders. And she's been prescribing cannabis now for probably, I would think, well over about 100 maybe of that order of people, something like that, which in the UK terms is a really old hand. So I'll stop emphasizing that now, Rebecca, and pass over to you. And thank you for just talking to us today.
Thanks, Mike. So I don't have any slides. I'm just going to talk for about 5 minutes, really just to give a sort of more of a narrative story of what brought me to prescribing and how it is to be a prescriber in the UK. And so my journey really began at university, where I had a friend who had a cancer diagnosis, and I watched her use cannabis very successfully to prescribe, to treat many of her symptoms. And then as I progressed through my training, I was lucky enough to be a Winston Churchill Fellow and went to Los Angeles and Stanford in around 2015, where it was really just there at the beginning of lots and lots of, well, being able to buy cannabis and lots of boutique cannabis shops popping up everywhere, but also looking at the work with veterans in particular, and lots of trials going on at Stanford. And really, I was really fascinated by how those trials were showing how effective medicinal cannabis could be for PTSD and trauma in particular. So I suppose I have a real interest through my career in trauma and how that presents. And then at the same time, I was also doing my training at the Maudsley in Southeast London, where the work of Robin Murray was very much telling us that cannabis causes psychosis. So I had lots of conflicting opinions, but was very much drawn to the work that I'd seen in America. And I worked with lots of prescribers there and was seeing how they were using CBD and medicinal cannabis to great effects. I think the other thing that really drew me was what we're talking about here tonight is real world experience. So patients' stories and voices. And often, particularly with trauma, particularly I've often worked with women who've had multiple traumas, and often there's a sense of stories being unheard. And I think that really is something that I, in my practice, I'm always very mindful of and really appeals to me in this field, because I feel that what we're doing is placing that patient experience and voice at the center of the work that we're doing. And I suppose I was very strongly drawn to that as well. So I've been a prescriber for, as Mike said, an old hand, emphasizing the old hand there, Mike, repeatedly, for around a year.
Sorry.
For about a year, and you know, mainly seeing people with PTSD, depression, anxiety, sort of chronic insomnia, but also with ADHD and sort of childhood trauma as well would be the main sort of groups of people that I've been working with. And I suppose going into it as a prescriber, you know, what really has struck me so strongly is how amazing the peer support has been in this process for me as a new prescriber. So everyone has been hugely generous of their experience, cannabis prescribers from all across the world, as is evidenced tonight. Everyone has been very generous in sharing their expertise, and it's really felt a very safe space to learn to prescribe in. Amazing support from people around us. I think that it's also for me felt very exciting to be sort of part of this new field, and I really feel that this will become the field of medicine over the next 5, 10, 15 years, and it feels really exciting to be part of that at the very beginning in the UK, and I've really enjoyed that. I think there have been negatives. You know, lots of colleagues have been critical, have implied that it's the wrong thing to be doing, have been very critical of the evidence base, and that's certainly been something to learn to navigate as a new prescriber in interacting with colleagues and in you know, trying to convince people of this without being able to give them necessarily 10, 15, 20, 25 trials. But again, that always comes back to me in terms of, you know, the patient experience and narrative. And, you know, in the very first people that I worked with and prescribed for, you know, one lady had a history of childhood sexual abuse. She's allowed me to talk about this repeatedly in lots of different spaces, but had been part of a paedophile ring, had had PTSD for 30 plus years. And within a month of starting medicinal cannabis, her symptoms were dramatically reduced. And she just described it as being absolutely life-changing. And she's continued to be really, really well. So immediately I could see how amazingly powerful this could be for people. And often the overlap, you know, lots of the people that I see with trauma might have pain as well, or physical symptoms. And you know, they would come in and say, actually, my PTSD is better, but also my IBS is better as well. So amazing results in virtually everybody that I've issued a prescription for as well. So that's my brief narrative about my experience. I'm really happy to answer specific questions. I can see there's lots and lots of questions coming into question and answers as well. So I'm going to stop there so that we've got time as a panel to go through all the questions.
Lovely. Rebecca, thank you very much. And thank you for being a pioneer in this field. You've done a great job. Thank you. So thanks to the panel. Now we've got 18 questions now. There's actually one I'll do. There was one that came on a text separately, so I'll read that first in case I forget it. And this was actually, it was to Richard, but I think anyone could answer it, or either Richard or Evan probably. Is there any evidence or experience of using medical cannabis for children with anxiety instead of risperidone or methylphenidate? I'm aware of a 10-year-old with cri du chat struggling with sleep, aggressive outbursts and anxiety on the above medications for the symptoms mentioned. Is there any role for medical cannabis, and would it be a more efficacious alternative? So that's for anxiety instead of risperidone or methylphenidate. Any comments on that, either Richard or Evan?
Evan, do you want to take that one? Because
Sure,
I think.
Sure. So I'm not aware of any evidence that's compared cannabis to either of those medications, but there's certainly some evidence in anxiety for adults. In kids, there isn't any kind of high-level evidence that has treated anxiety in particular. In terms of my own experience, I do, though, treat anxiety in children. And in what conditions? Typically in autistic children. So we find that in that, and there is evidence that you can extrapolate from two big studies that were done, that were open label studies out of Israel. Both use a relative THC predominant course, so mainly THC, but a significant amount of CBD as well in autistic children, and things like aggression, rage attacks, and just general ability to interact. That all kind of was improved with medical cannabis. So you can imply that anxiety is being treated there, And I see that a lot, and I see that mirrored in my autistic patients. They do benefit from medical cannabis in general. There are certainly those that do not respond. And other areas as well. I have probably 2 or 3 children I treated with primarily at their anxiety, but again, it's not an area that I work with particularly in children. Now in adults, in the concussion cohorts, you have a lot of anxiety. So we typically target the anxiety in the concussion patients. And I'm talking more about the persistent post-concussive symptoms. So the used to be known as post-concussion syndrome. We're moving away from that, but these are people with concussion symptoms for long periods of time. And I find this helps, just anecdotally, this helps their anxiety a lot. Medical cannabis is a good intervention in concussion because you can hit a lot of the concussion symptoms, and one of them being emotional dysregulation and anxiety.
Yep. Thank you.
Also in
Sorry,
kids
Richard,
in patients with Tourette syndrome as well too.
Yes.
That where
Yes.
a lot of times the tics are driven in many ways by anxiety, and THC predominant therapies has been shown to be helpful in reducing tics in those patients as well too. And my experience as well in our patients has been that they report improvements in anxiety as well as improvements in their tics.
Great. Yes. Thank you. Yeah, I shouldn't forget Tourette's. That's part of those in the UK know about the Drug Science 2021 program, and Tourette's indeed is one of the allowable conditions in that trial. So there's emerging evidence now quite reasonably strong for treatment of Tourette's. Questions on the screen. Kate, can you just answer for me? Can people see these questions can everyone see these questions on the screen?
No, the questions can be seen when they've been answered. So as they're answered live,
okay,
so if you read them out.
Thank you. I'll read them out. Graham McFarlane was the first one, and this is perhaps, Graham, a statement which is a very interesting one rather than a question, but in an interview with the Pharmaceutical Journal in December 2020, Gillian Leng, who's the newly appointed Chief Executive of NICE, responded to a question about the role of observational studies and data-driven research, and her response was very positive. But RCTs will no longer be the only route to recommendation, and the data handling systems and processes have been changed in NICE to properly evaluate whole real-world evidence. The paper was signed off by the NICE board last week, allowing for a more pragmatic approach to innovative medicine and evaluation. And this must be properly designed with the clear patient cohorts and expected outcomes, of course. Add to this the launch of the MHRA, that's for those who are not in the UK, that's the regulatory authority that approves medicines in the UK. The ILAP scheme, ILAP, which I've forgotten totally what it stands for, but it's an innovative medicine scheme, basically, Early Patient Access to Innovative Medicine Initiative. Together with that agreement between NICE and MHRA for increased collaboration, are we witnessing a real change towards accelerated access to medicines such as medicinal cannabis? But I think we can all say, I really hope so, because I said right at the beginning, we've NICE has been and maybe they were constrained by that. I don't know their regulations, but they were far too constrained by the pharmaceutical approach and the double-blind study. So it's lovely to see that they are actually now seriously considering real-world evidence. And indeed, the previous chair of NICE, Sir Michael Rawlings, made that in a Harveian oration at the Royal College of Physicians about 5 or more years ago now, who said that, there's a lot of evidence to be considered. Double-blind placebo-controlled trials may be at the pinnacle of that evidence pile for the right product, but it's not the only evidence we should take into account. That was the chair of NICE said that. It's sad in many ways that it's taken 5+ years for that to filter down to the workers of NICE, but it's lovely to see that that's happening. So Graham, thank you very much for pointing that out. Maybe we're beginning to see chinks in the pharmaceutical armor, if I can put it that way. Next question is anonymous. Is a cannabis prescribed for ADHD or bipolar disease? If yes, how does it help patients? Anyone want to answer that? ADHD and bipolar? Yeah, Richard.
So one of the pediatric psychiatrists I work with in Saskatchewan has a real interest in pediatric ADHD, and he does authorize cannabis for children with treatment-resistant ADHD. And he reports that it has been very helpful in some of his patients. So
yeah, thank you. And
I add to that as well, just briefly. So yes, for adult ADHD patients, it can be really helpful for adult ADHD patients. both as an oil or vaping. And also in bipolar, you know, clearly bipolar, you have to be incredibly careful about the use of anything with THC in it specifically. But I do have one patient who has bipolar, who has also a lifelong social anxiety. And he has been taking a low dose of CBD and has markedly reduced his anxiety, and he hasn't had any manic episodes. So the answer is yes to both, but you know, with due caution.
Thank you. Okay, well, we're fairly quick because about 18 questions now. From Claire Navas. Have you found that treatment with full spectrum is more effective than broad spectrum or singular compound, but that's isolates, with your patients with epilepsy? We've sort of answered that, but Evan or Richard, do you want to have a quick recap on full spectrum versus broad spectrum versus isolate? Which do you find best in your practice? What would you try first, I suppose?
So, well, in Canada, we don't really have access to the isolate, so we use for whole spectrum product.
Right.
But you know, when you look at the data, and there's been a few meta-analyses done looking at this, comparing the pharmaceutical grade CBD versus the whole plant extracts, and the evidence in these meta-analyses is very suggestive that whole plant extracts are more effective. And so really kind of getting into this concept of the entourage theory that cannabinoids act more effectively in synergy than in isolation. I think but also you have to look at doses as well too. So when you look at the doses in the whole plant extract, the CBD rich extract studies, the CBD dose is often much lower than the CBD dose in the purified studies. So there is that suggestion, a strong suggestion that that is the case. Yeah. I would say though that really though, I think you do need to do a comparative study.
Yeah.
Yeah, I just posted that here, Richard, and that meta-analysis you're talking about, which shows that difference. And the biggest standout thing here is what happens with the adverse effects when you get to higher CBD doses. That's probably right, with relative equal seizure response, more or less. But I think what it speaks to too is there's a role. There's certainly, the way I think of it now, there's a role for the purified CBD compounds, and there's a role for the CBD rich extract. So it really depends on my patients. So some patients are absolutely, they don't want anything to do with THC for whatever reason. That's okay. So we do now have a CBD isolate or a purified CBD formulation available in Canada for prescription. It just started in November, actually. That is available. So now I like that it's there because it gives me the option for other reasons too. You can have some patients who have, in the past have had significant effects, side effects of THC. So it allows you to play with both. Yeah.
Thank you. Jack Hughes, how do we get the government, the NHS and MHRA to listen to real world evidence? It feels like the UK's ability to prescribe medical cannabis is being left behind globally. I think that's true. With 50 countries of now, medical cannabis is legal in various shapes and sizes. So we are on that list, fortunately, but we are a bit behind. I think, how do we influence? Well, it's nice to hear that they're influencing themselves from Graham's initial comment. And it is a matter of continual lobbying, I'm afraid, and continual pressure. And what will be really important is the doctors who believe in this is to push it for their patients. And I hesitate to get political, but once you give me a microphone, it's always a danger. That actually there are doctors out there, we know many, who want to prescribe medical cannabis are being stopped from doing so by their National Health Authority, by National NHS trusts. Because oddly with cannabis, they'd have to get approval. You can't just prescribe by yourself. You've got to go and get it approved by a multidisciplinary group or the medical director or the chair of the clinical governance committee or whatever it's called. And they won't go against things like the NICE guidance. So we do need, in fairness, it's totally legal for doctors to prescribe. We need them to get on and prescribe it in the best interest of their patients and not in the best interest of their own careers. Stop getting political at this point, because Kate will probably cut me off. So I will move on to Rayan Zafar. Nearly all the cases in the British observational case series of the Endar Pain cohort, that's a lobby group for those who don't know, Epidiolex alone was found to be ineffective in reducing seizure frequency, but combined with THC and CBD, a combination of CBD and THC was necessary to achieve reduction in seizure, so which echoes your findings, Dr. Lewis.
Yeah, I was just going to mention that. Absolutely. Obviously, from the parents I know and my experience is that many children with refractory epilepsy fail isolate products, and they need the full plant products with the extra minor cannabinoids, terpenes, to have really good control of seizures. So, you know, yes, that's an anecdote, but as drug science have very kindly gathered all that data, it becomes less so. It becomes more about real world evidence. And we're very, very grateful to drug science and Ryan for doing that work. And we'll continue working with them to produce this data, because actually no one has been interested in this data from my son and from other children, and actually it's really, really interesting data, and we should be publishing it. So thank you to them.
Thanks, Hannah. Anita, just a thank you for sharing. I'm a clinical pharmacist in BC, Canada, and we need more education around medical cannabis. I agree with you, and hopefully this is a step in the right direction. Cheryl Fitzatas, remarkable effects in some people, as Prof. Barnes mentioned. Can panelists discuss research being done to understand what makes certain people responsive and others not? Endocannabinoid tone, biomarkers, question mark, etc. Richard or Evan or Becca, anything about why some people respond? And it's not everyone, like any medicine, not everyone responds to cannabis. It's not some magic pill. Why do some respond and some not? Do we have any clue about that?
So one of the theories that was postulated about children responding to cannabis for their epilepsy was that actually the cannabis was increasing the levels of other anticonvulsants, such as clobazam was the big one. So in the PRE study, we looked at at levels of at anticonvulsant levels, and sure, the clobazam levels increased due to the pharmacokinetic effect interaction between CBD and clobazam, but seizure control seemed to be independent of that. And in patients who are taking clonazepam, similar medication, different kinetic pathway, the clonazepam levels didn't increase, but the seizure control increased. So it suggests that there is definitely it's not just enhancing the effect of other anticonvulsants. You know, one of the studies that we're proposing in Canada, and Evan is part of this, is we're going to try and include pharmacogenetic analysis, looking at the genes involved in the enzymatic pathways of the endocannabinoid system, to see if that has an effect on response to cannabinoids as well.
Yeah, thank you, Richard. We'll move on fairly quickly because there's still 18 questions to get through, and we have exactly 15 minutes to do it, so I shall plow on. Nathan, incidentally, is one of our pioneering prescribers for children with epilepsy in this country, and thank you, Nathan, for stepping up and doing that for those children. He asked, what maximum levels of THC do you use in children with epilepsy? Either of Evan or Richard, any answer to that? Maximum level of THC.
I think Richard has some good evidence from the PRE trial. We also have good evidence, Nathan. Look to those CBD-rich extract trials, and please reach out. I can send you the list of those 4 trials, or the 3 trials, and I'm sure Richard can send you his information as well. But there is a guide there to show what was tolerable in terms of THC amount. So it looks like around 0.5 to 0.6 milligrams per kilogram per day, when in combination with CBD. So 0.5 to 0.6 milligrams per kilogram per day, up to about 30 kilos, 35 kilos. That looks tolerable. That appears to be tolerable, i.e. you do not get the euphoric or the intoxicating side effects of THC. I have had to push those doses in some kids. And then if we're coming out of the milligram per kilogram per day dose, so that's about up to 30-35 kilos. After that, roughly 15 milligrams, 15 milligrams of THC per day, split 7.5. 7.5 is an example. That seems to be a safe, tolerable level of THC.
Yep.
In the context of CBD, with CBD on board.
With CBD, yep.
And in the PRE study, we actually looked at CBD and THC levels in our patients. So steady state THC and CBD levels. And even at the CBD, using a 120 extract, even at a dose of 10 to 12 milligrams of CBD per kilogram per day, so 0.6, milligrams of THC per kilogram per day, we found that in almost all the patients, the levels did not go above that which would be expected to cause intoxication. Plus, we also looked specifically for signs of intoxication in our patients, and we didn't see any.
Thank you. Edward and Milne, is there a list of cannabis medications currently available in the UK? Yes, there's one on the Society website, and Matt, also from MedCann support, has a similar listing. So yes is the answer for that. Join the Medical Cannabis Clinicians Society. Thank you, Edward. That was a perfect segue into my second speech about joining the society. Anonymous attendee, with regards to CBD maxing out, is this related to tolerance buildup or another pharmacological pathway? There's a secondary question on Quinn's evidence of tolerance buildup. I think Evan answered that in the actual talk. So anything about why there's tolerance buildup in CBD after an average of 11, 12 months? Do we know? I don't think we do, is the quick answer to that, but
I don't think we do.
no,
Yeah.
there seems to be some consistency about the 11, 12 month mark, though, doesn't it? I don't know why that is, but the Epidiolex studies showed that as well, didn't I? I think the average was 11 months or something of that order. Yeah. So I'm afraid it happens. There's ways around it, but we don't know why it happens is a quick answer to that one. Right. How do we collaborate at a global level? This is from Anita Rosoda. For standardized approach to dosing guidelines. It's a good question, because it's you know, there's a lot of experience around the world now, not just from Canada and the States particularly, but now increasing evidence from Australia, Germany, many other parts of the world. And you know, if we only shared that experience of what is now, you know, hundreds of thousands of patients in all sorts of different conditions and thousands of doctors prescribing, we get there so much quicker with real world evidence. And how do we do that? I wish I knew the answer. I mean, I think we do need some sort of global organization that does this. There are International Cannabinoid Medicine Association. I'm sorry to admit slight ignorance, but some of those international, or two international organizations, really focus on the neuroscience, which is great. I mean, they need scientific collaboration as well, but I don't think there's an international organization. It's, if you like, a practical prescribing physicians organization. Perhaps Evan or Richard or Becca can correct me. I don't think there is, and maybe we should get on and do that.
Some more work for us there.
It's more work there.
So
I thought this was the start of it, Mike.
Yeah, well, I did open my big mouth at the beginning and say we need to move the UK society to become the global medical. So maybe I think there's a real benefits to had from doing something like that.
So, and that was one of the things I was so wondering about before I gave my talk is, you know, where the real world data comes from. So, you know, in Canada, unfortunately, a lot of the patients, quite a few patients access cannabis through clinics which are owned or run by licensed producers. And so it kind of, you have to, it does raise questions about the data, but, you know, there is no reason why there couldn't be a global database for patients to, but it would have to be easy to use for physicians to enter data about, anonymous data about their patients, but in a very standardized way, so that you can try to then say, for instance, if I enter data that you in the UK could access, and vice versa, or anywhere in the world could access that data. Yeah,
it's doable. I'm parking back to a previous hat when I was president, I think, of the World Federation of Neurorehabilitation. We did just that at a very basic, if you like, real world evidence, very simple to collect for spasticity management globally. And we got many thousands of people enrolled in that study. It was very simple, basic, but it gave very sensible real world answers very quickly. Once it was set up, they got the answer very quickly. So something like that is quite doable. We just need people to do it. So perhaps the 1, 2, 3, 4, 5, 6 on this panel can do it.
So I have a disclaimer to make. I am terrible with technology. Even to log on to this talk, I had to get my teenager to help me log on. So
okay. Okay. We'll use an advisor rather than the technical expert then, Richard, shall we? Tim McDonald, can you clarify the current understanding regarding cannabis and psychosis? Rebecca, do you want a quick, that's a long, complicated question. We've only got about 30 seconds to do it. So do you want to do a brief summary of psychosis?
Yeah. Yes. Okay. So, you know, if you look at people diagnosed with psychosis as a group, they're more likely to be currently using cannabis or have used cannabis in the past. But I think what you have to be really careful about is the distinction between causation and correlation. So if you also look at the population, you know, the increase, say, from the 70s to 1970s to over 30 years in the amount of people smoking cannabis, you don't see a similar equivalent increase in psychosis. So there is absolutely a group of people for whom their psychosis will be triggered or made worse by smoking cannabis, and that's usually high potency THC and usually on a daily basis when you look at the literature. But over the population, many people will be smoking cannabis and not having psychotic symptoms, in a nutshell.
Thank you, Rebecca. Interesting one here from Arthur Quizira. Forgive me if I'm not pronouncing these right. This is great work. I'm I can never say that word, anesthetist, thank you, in Uganda. So welcome. We're considering a clinical trial on sedation for critically ill patients undergoing mechanical ventilation in our setting because of known side effects, as well as access in low resource settings, as well as pre-medication for anesthesia and general anesthesia patients. We could also consider it for all manner of seizure-related activity in all patients, including preventing eclamptic seizures. So which industry partners will be willing to partner with us? We do not have the same restrictions in Uganda. I'm happy to partner with anyone. Arthur. Thank you, Arthur. That's very interesting. It's lovely to see enthusiasm from other countries that have not yet sort of embraced it fully, to put it that way. And I think maybe, Arthur, if you want to write to me and we could then see if there's anything we can do to partner together. And maybe then you can be the African representative on the just formed Global Medical Cannabis Society. So if you drop me a note, we can, or Kate, you've probably got Kate's email on this invite. So if you drop in a quick note to Kate, she can forward it to us and we can try and answer you. Finally, Sarah, I have a meeting with Rebecca Moore next week. Oh, there you go, at the start of my 2021 journey. I've also been approved for CAN card. Is there any way I can access medicinal cannabis now without going down the illicit route? Rebecca, do you want yes is the quick answer to that, but I mean, not before you see Rebecca, no, but legally.
No, yes.
After seeing Rebecca, if you're suitable, the answer is yes. CAN card, for those who don't know, is a very recent innovation in the UK where people who would be eligible for a prescription but can't afford it can get a card. When they're growing their own or buying it effectively illegally, they can prove to the authorities, should they be stopped or searched, that they're actually using it for medical purposes. It doesn't have the weight of law behind it, but it's a step towards decriminalization, which I think is very good for medical patients. Daniel Allen, what products do you tend to prescribe, Becca?
Gosh. Well, I mean, I think that's one of the things that's also changed over the past year is the amount of products that I'm able to prescribe. So, you know, it's very much based upon each person and what would be best to treat them. So it might be oils or flowers or a combination of both. And, you know, we now have around, oh gosh, I think about 30 products on our formulary, whereas there was literally about 4. So we're really lucky in that we're able to choose the right ratio, whether it's an oil, whether it's a full spectrum, whether it's a indica type, you know, so it's really very much bespoke to each person. But it's brilliant to be able to prescribe so many more products.
It's growing very rapidly, and we're now beginning to see a little bit more subtlety in the products. A little bit more understanding of the minor cannabinoids creeping in and terpenes creeping in. We're still a little bit focused on THC CBD ratios, but you know, as Becca says, we've got 30-ish products in the UK now, so pretty, compared to a year ago, I mean, it's extraordinary progress. I must stop prattling on because we've only got 3 minutes now. What products do you tend, oh, sorry, we answered that one. How long does CBD take to work for anxiety and depression from a traumatic event?
It's very variable again, but I've seen people show a response within a month. But I would say, you know, we really would tend to see a cumulative improvement over 1 to 3 months. Say, sometimes it's about getting the dose right, sometimes it's about getting the ratio right, but it can be very, very quick. Yep.
Can the panel speak to treatments for essential tremor in terms of the optimal CBD and THC ratio? Wow, that's a I would take the chairman's prerogative of asking someone else. Evan or Richard, do you see him with central tremor? I think the quick answer to that is we don't know. It's very much trial and error. It's the old start low, go slow. I always start with high CBD and add some THC if necessary, but probably in essential tremor, you need a bit of a balanced product between the two will be my answer. But I don't know if Evan or Richard have said more experience, possibly not in children for essential tremor, but what do you think?
Yeah, I see adults as well, but I haven't had anybody come to me for essential tremor, but I would do the same. So whenever that happens and someone does come and they're really adamant about it or really a desire to explore that path, then knowing that I'm comfortable with the safety and tolerability of low doses, I start low dose, so assuming they're otherwise a healthy person with no contraindications.
Exactly. Yeah. Thank you. Can the ability, this is from Cohen, can the ability for patients to discuss and be prescribed medical cannabis prescriptions allow for a more transparent and confident medical assessment with significant consequences? I think that's, yes, absolutely. Yeah. That's good medicine, and that's medicine we should be applying to cannabis as well as any other medicine. We need to involve the patient, the family, the carer, whoever it is, in that consultation. And often in cannabis, of course, it's patient driven. Actually, these days, certainly in the UK, we get patients coming who are frankly an awful lot more knowledgeable about cannabis than the doctor.
I think in our patient population that Evan and I see with our pediatric patients, it really allows us to have a good discussion with the parents and say, okay, these are the potential side effects you need to look out for. Right. And so if you see this, you got to I need to know about it, as opposed to parents doing it, the illicit route, which we used to see before, and they would and then, just having that ability is so important.
Yep. Agreed. Jamie Bartley. Hello, Jamie. Jamie is perhaps one of the country's leading experts on hemp, running a company called Unite. There's a plug for you, Jamie. To all the panel, thanks for the presentation. Which cannabinoid do you think shows the most potential? That's you, Kate. You took it off before I'd read it. Most potential for, what was it? Kate, you'll have to tell me.
Sorry about that. I just was saying that you were answering it live. The question was about the most interesting cannabinoid for research.
Thank you very much. Yeah. The most interesting future cannabinoid, perhaps for research. Is it going to be, what is it going to be? THCV, CBC, CBG? Pick a collection of letters.
I'm gonna take maybe an unobvious one. I think it's, well, I mean, looking at epilepsy, I think it's THC right now.
THC.
Well, yeah, I think when we really have a good understanding of THC, that will allow further understanding of the other cannabinoids. And given we have so much information about THC already, we should utilize that information and really dive into it. That's right. So for the immediate future.
Okay, thank you. It's now 7:31. We've got 10 questions outstanding. What I suggest, obviously people can leave and some are, because it's 7:30. I suggest if it's okay and if the panel's all right with it, we just go through these last 10 questions, but maybe people could kindly not add any more at this point, otherwise we'll be here all night. So we'll go through those existing 10 questions. So another one from E. Cohen. How important is consistent cannabis product? Are patients more inclined for constancy or variety?
My patients, I think consistency is important because I have seen, there is variability batch to batch in these products, even from the same licensed producer. And I have seen changes in seizure frequency that when you look back at it, probably relates to changes in the batches. So I think for me, consistency is important.
Yeah, I just want to jump in there quickly. I totally agree, but I think that we mustn't lose the benefit of the whole plant in the pursuit of consistency, because then you don't have such an effective product. So I think it's about, yes, we should have a degree of ensuring that consistent, you know, the variation, let's say, doesn't go too far out a certain percentage. But I also don't agree with sort of, you know, batch to batch sort of isolate products being built up into what are supposed to be whole plant products, because they're having cannabinoids added to each other, because actually they're not as effective. So yeah, I think that you can do both and yeah, still be safe, I think.
That leads us nice into Matt Hughes. Hello, Matt. Matt runs MedCann support. A question about epilepsy. Would Evan or Richard use isolates, e.g. CBDV, as an add-on therapy to a whole plant extract?
Short answer is yes, and I've done it. So
yes, you've done it. There you go. Okay.
Me too. With the THCA, but I added on. But that also, it wasn't an isolate. It was THCA, THC. I think it was a 15:5 ratio.
Right. And I've added on CBG to a regime as well, with good effect. Andrew Bref, Andrew is another one of our pioneering prescribers. Hello, Andrew. Any thoughts about risks of neurodevelopmental effects versus seizure control with THC in children? I would assume the risks of recurrent seizures are likely to outweigh the CBS effects.
Yeah, I can speak to that briefly. So certainly that's always a concern. So we have no long-term adverse effect data on CBD or THC. So they're big black boxes. In terms of medically prescribed CBD and THC. Now we do have data with recreational use in THC. So we do have fairly good data that shows high THC potent cannabis used in frequent amounts and chronically in adolescence leads to future structural changes in the brain, behavior, mood issues, and decrease in IQ. So there certainly is exposure to large recreationally used amounts of THC has long-term neurodevelopmental effects. That is an absolute. But when you're using THC in a through a medical lens, you should never be achieving those similar doses. So I think it's still a black box, and we don't know. But I think the last part of that, Mike, that was listed there, and that was, well, then you have to balance against ongoing seizures, right? And with epilepsy, right, specifically if that's what we're talking about, it's always a question of the side effects and benefits of the medication versus the risks of
like everything.
And one has to consider too that there's good basic science evidence for the protective effect of CBD as well, and there was a good study which showed that CBD prevented some of the structural changes associated with THC.
That's a great point, Richard, because obviously when you're using THC recreationally, there's little to no CBD in that, right? So you don't have the concurrent protective effects of CBD. Good point.
Thank you. Ryan McCreenaw. Ryan, another advert here. So some people I know. Ryan runs an organization called Sativa Learning, who's done an excellent teaching program for CBD pharmacists, and is going to work with the Society on developing a medical practitioner's training course. So hello, Ryan. He says, chronic pain is a common reason for medical cannabis use. Indeed, it's about 2/3 in the clinics. Are the panel aware of any evidence to suggest that cannabis use can increase pain in certain people? I've personally experienced increased pain from a cannabis consumption. That's an interesting question. Has anyone come across it?
I'm not, and again, I don't deal predominantly with pain, but that's an interesting observation.
It is interesting. I looked it up recently, Ryan, and it is reported in about 1%. It's not very, very sketchy evidence, but it is not unique. But why it happens, I have absolutely no idea, I'm afraid. I've personally not seen it. Raquel Perob from Uruguay. So we've got a very good international audience tonight. Hi, everyone. I'm an MD from Uruguay working with cannabis and cannabinoids. And this is about, actually, we've sort of answered this, Raquel, but thank you for asking. I'd like to know the experience with essential tremor. We've answered that. There is limited experience with probably a balanced product is the best guess, but we certainly need more studies on essential tremor. Is there any place in use for agitation in Alzheimer's? Yes is the answer. There is some evidence, as far as I know, for improvement of agitation in Alzheimer's and dementia generally, isn't there? If anyone wants to chip in on that, not so much the dementing process, but agitation and, of course, other symptoms in dementia like anxiety and sleep and what have you, appetite. But yes, there is in terms of agitation in dementia. Yeah.
One of my colleagues in the Cannabinoid Research Initiative of Saskatchewan is hopefully going to be starting up a study looking at cannabinoid at CBD rich extract for patients in a long-term care setting with Alzheimer's for anxiety and agitation.
Right. Thank you. There's a couple of questions gone past. Katie, does that mean you're going to answer them, or we're going to answer them by typing later?
Yes, we'll come back to those later because they're a bit more involved.
Okay, thanks. There's two more then. Can vaping give a more immediate relief for anxiety? Yes, is the answer to that.
But not sustained.
Becca?
Yes.
Not sustained. Would it be used for Becca, for example? You get the breakthrough pain for vaping, but what about panic attacks? Would that be a role for vaping if you used it for that?
Yeah, I've definitely got people that when they can feel that coming, they would vape, and it works really well.
Yes, yes. You get that bigger boost in the plasma levels, don't you? Yeah. So yes is the answer to that. And the last question for tonight, and those who have asked questions that we haven't answered verbally, we will answer them. I promised. There was one, for example, on levels in the blood for driving and such, like sort of technical answer. So last one to answer, then we'll finish, is what is your view regarding somewhat conflicting evidence regarding cannabinoids THC impairing brain development in children and adolescents? While that is balanced by improved neurological function in severe epilepsy, what is your opinion regarding using it for other conditions in pediatric, such as chronic pain, in a pediatric population?
Yeah. I would say very similar answer to what I had previously said regarding the epilepsy. And you got to balance the risks versus the benefits, and a lot of that is probably going to be the experience of the prescriber. So I have a lot more experience, so I feel that this, the safety and tolerability to some degree, I have a good sense of a good hold on that. So I might be a little bit more liberal in prescribing compared to another colleague. But again, I always weigh the benefits and risks and make sure parents are informed and understand that there's a lot of unknowns about the neurodevelopmental consequences that may potentially arise from cannabis consumption that we just don't know.
Okay, thanks.
So for instance, in patients with Tourette syndrome, and Evan, we've talked and something we've discussed too is kind of building a foundation of CBD before introducing the THC, right? So, trying to take it in a very kind of a logical approach, haven't we?
Yep. Two people have sneaked in 2 extra questions very naughtily, but we'll answer them. No more after these 2. Anita, how do you approach chronic pain management? Is there a guideline for patients who are opioid naive and those who wanted to go off opioids? That's actually quite a long answer. Very briefly, my approach, as we've said, is I start with CBD, which can be helpful for pain, particularly for the associated problems of pain like sleep and anxiety. Good night's sleep and less anxiety does help pain. And of course, CBD can be somewhat analgesic in its own right. But then my view of pain is that we do often, and nearly always, in fact, need THC added in. And severe pain, neuropathic pain particularly, does need sometimes quite high THC. It's the only one I think that sometimes does need quite high THC, as long as it's covered with CBD. So I think it's the go slow and start low and go slow again, isn't it, really, with chronic pain, in a nutshell. So that's a quick answer. That's a whole webinar in its own right. The last one, ladies and gentlemen, can you tell me if there's any negative effects on fertility for both male and females using CBD? Becca, anything on that one?
So there's not very much evidence. Most of the sort of negative effects tend to be with THC rather than CBD.
Yeah. You've frozen.
CBD for women in particular, that might be helpful in terms of, that CBD for women might be helpful, but really there isn't very much out there at all. It's mainly around THC.
Yeah, there's a couple of papers, but very, very little, isn't there? Yeah. And that, ladies and gentlemen, is it. It's now, apologies, we run 12 minutes over, but at least we got through all the questions. I think we answered 42 questions there, it says. That's very good. And I say a few we'll type an answer to a bit later on. I was going to do my spiel for the society again, but people would be completely turned off if I do that again. Just look on the website, ukmccs.org. And also, for those appropriate, please also join and look up the MedCann support. Many thanks to the panel, Richard, Becca, Evan. Kate for organising all this, the Jamaican Medical Cannabis Corporation for supporting it, MedCann support, and the MCCS for putting it together. And next week, Kate, do you just want to say next week is?
It's access and ethics of medical cannabis, putting you in the spot. Yeah, so everybody who came on today will be invited to that event, and also I'm going to be sending you all the recording from today. Like I said, if we didn't get to your question, we'll also do our best to answer via email.
Thank you, Kate, and thank you, everybody. And on that, I wish you all a good night or a good afternoon or a good morning, wherever you are, and we'll see you again. Thank you very much.